Okay, guys, so unfortunately, the video that I posted looks like the volume, like the speaker, microphone, whatever was not recording like halfway through. So here's the new recording. Hopefully everything is smooth this time. So sorry for the delay. Okay, so respiratory system. So, when we're talking about the respiratory system, we are talking about respiration. And respiration has three parts. The first is ventilation, and ventilation is the actual movement of air in and out of the body. So, what we know as breathing. So, inhalation and exhalation. Now, gas exchange is what we're talking about on obviously like a molecular level. So, gas exchange occurs between the air and the blood, okay? Of course, at the lungs. And then in your body, it's going to be between the blood and your tissues. So, this is actually getting the oxygen to our tissues and removing carbon dioxide from the tissues to breathe it out. Lastly, we have the utilization of oxygen. And we're not going to focus too much on this process in this class since it's one unit, but this is the whole reason why we breathe, right? Is to actually utilize this oxygen in our cells to make ATP. So, hopefully, you recall that during the process of aerobic respiration, um, we need oxygen at the very end of this pathway, specifically in the electron transport chain. The electron transport chain essentially needs a final electron donor, and oxygen is able to serve as that. Okay, so three parts of respiration. Again, we're going to focus mainly on ventilation and gas exchange for this class. Okay, so there are four main rules of ventilation. Like I just said, the first being gas exchange, right? To deliver oxygen to our tissues and then remove carbon dioxide. That is what we know and love in terms of ventilation. Second would be acid base balance. So we can use these buffers in our central nervous system, along obviously with our breathing rate, to adjust the blood's pH. Okay, we want to make sure that the blood is not too acidic and not too basic and is essentially slightly almost neutral to make sure that we're in homeostasis. Now, the last two functions are kind of forgotten um, when we go over this system, but still important. So, the immune function. You probably didn't think about this, or maybe you did, but when you're doing things like coughing and sneezing, that is your ventilatory or respiratory system working. And it's working not only to get you oxygen, but in this case, to protect you as an immune function. So, of course, coughing, sneezing, but also we have lined in the tract, which we'll talk about, we have certain cells that have cilia, and then we produce mucus to kind of trap and push out any pathogens that could get in through our airway. Since, of course, there is a lot of pollution, allergens, etc., in the air. And then lastly, sound production. So, sound production, or our voice, is essentially due to the movement of air across our vocal cords. So here's the vocal cords, like if you were looking down into the throat, and you would have them opened here. Down here would be the trachea. So when the vocal folds vibrate as air crosses, those vibrations create what we know as sound. Okay, so before we jump into it, quick review. The movement of oxygen onto a red blood cell is achieved by which type of membrane transport? So you can pause it, pick your answer. Okay, so hopefully you said three, simple diffusion. So oxygen is a gas and it is moving onto a red blood cell from the lungs. Yeah, down its concentration gradient. Oxygen doesn't need help, so that's what makes it simple. All right, so here is the overall picture of our respiratory system. Now, I just kind of briefly want to touch on the important parts of this anatomy, but again, it's not anatomy, so don't stress too much about these details. I just want to orient you so you kind of know where we are. So, of course, our respiratory system starts off with air getting into our body through either a nasal cavity, okay, via our nostrils, or in through the mouth via the oral cavity. Now, it's important to note that the nasal cavity or nasal breathing is actually a more preferred way of taking in air or breathing in oxygen. And there's a few reasons for that. One is an immune function. Um, you have nose hairs, which most of us think that is quite gross or annoying, but those are actually very useful and they do serve a purpose, and that's to create a barrier and filter out allergens and pathogens. Then we also obviously have some mucus, and it's lining these mucous membranes inside the nasal cavity. Now, within the nasal cavity, it's a little hard to picture from this angle, and I'm not going to test you on this, but just like a fun fact, we have these bony prominences within our nasal cavity called nasal concha. And these nasal concha are like these little like swirly bones that essentially slow down the movement of air so that it has time to warm and moisten before it goes down your pharynx or your throat. And I'm sure some of you have kind of experienced this before. Like if you are breathing heavy, say in the cold, like you're snowboarding or skiing in Mammoth or whatever, you'll notice that the air doesn't feel too great when you breathe it in. It's a little harsh, and that's because it's not warmed, right? The air is super, super cold and lacking moisture. So your nose obviously tries its best to combat that, but in general, we prefer to breathe in, or our body prefers that we breathe in through the nose for immunity and also to just moisten it, get it warm so that it goes down much easier and honestly a little quicker. But either way, we get the air in via either the mouth or the nose, and it's going to end up here in the back of the throat. And if there's two kind of routes it can take. We can either send that air down the back of the pharynx and towards the esophagus, but that would be going towards our GI tract, and that's not where we want air to go. So instead, what we can do is push the air forward into our larynx. And our larynx is, like I said earlier, that is where our vocal cords are that are going to vibrate and help us create sound. Now, passing the vocal cords, we are now in this cartilaginous um, pipe, if you will, and this is called the trachea. Now, if you put your hand on your throat while you're talking, you can actually feel the vibrations from this structure here in your larynx. And you can see here, these are cartilaginous rings and they continue over here. It just looks a little funny because his head or her, I don't know, is turned to the side to kind of show us these structures. But then in the middle, it's kind of an anterior view. But regardless, the front, the anterior aspect of our throat, obviously internally, is critical. Okay. This pipe, what you would think of as your windpipe, okay, this is your trachea. And if this trachea collapses or there's something in the way, you can't get oxygen. Okay. So it's very critical that we have these cartilaginous rings to hold the tube open no matter what. Okay. No matter if you're lying down, standing up, if you have compression, they must stay open. Okay, so air is now traveling down the trachea where it's going to branch out into the left and the right bronchi, okay, or bronchus is singular. Okay, you don't really need to know all these terms, but what's important to know is that all that's happening is air is flowing through a bunch of tubings up until this point. Okay, there's no gas exchange. Nothing is happening. All we're doing is providing a pathway for air to flow. And even so, as we get deeper into the lung tissue, inside this is what we call our bronchial tree, where it's bifurcating, getting smaller and smaller into what we call these little bronchioles, which are these tiny branches. We still don't have gas exchange until the very tips of these bronchioles at the structures called alveoli. So it's these little bunches that you see down at the very ends. And that is where we're actually going to get gas exchange. Okay. So the respiratory system, in all honesty, majority of it is just moving air. We only get action deep in the lung tissue. And we'll talk about this in depth in a moment. But the last structure I want to highlight before we move forward is this muscle here. This is your diaphragm, okay? And this is a skeletal muscle, the most important skeletal muscle, in my opinion. If your diaphragm is unable to contract, you are unable to breathe. And we'll talk about the mechanics as to why. But for now, you have, okay, your two lungs that are receiving oxygen from this trachea to your bronchus to your bronchioles. And then we have this diaphragm down below it, sits right under your lungs. That's going to help us to push air in or out. Okay. All right, so now let's take a look inside of these tubes. Okay, so again, we kind of refer to this as the bronchial tree, everything in blue, where we're not talking about the true lung tissue, but rather the kind of like tubing. Okay, it truly is a tube for air. And we've already discussed how it is held open by cartilage and how we're getting these bifurcations, which are going to help increase surface area, which is good because the more surface area, the more oxygen we can bring in. But now we're going to look at the inside of this tubing. So down the tube where air is flowing, we will find these cells lining the tube. And these are called pseudostratified ciliated columnar epithelial cells. Okay. These are super important and they're kind of cute. They kind of look like anemones, like, I don't even know how to say that, but anemones, from Finding Nemo, where their cilia up at the top are beating in a certain direction. They're creating a current, like the ocean does. And the purpose in this case is to line this tube with cilia that can push all of the bad stuff that you inhale up and out so you could cough it up. Okay, so this is what like they actually look like under an electron microscope, of course, but I'm not going to test you on stuff like this. Here's just like the cartoon version to kind of explain what it looks like. So these tan cells, you see their little hairs on the top. These are your pseudostratified columnar epithelial cells. Okay. And the name pseudostratified comes from the fact that they are in a single layer, but pseudo stratified means they look like they're actually in two layers, and that's because their nuclei are on differing levels. So it kind of gives the impression that there's two layers of cells, but there's only one. So that's just where the name comes from. And then, of course, columnar, they're column shaped, ciliated, they have cilia. Okay, great. So those cells, their job is to trap pathogens and push them up and out. Now, to make this work even better, we have these cells here in green. These are called goblet cells, and they secrete mucus. Okay. So they secrete mucus up and out onto the lining, and along with these hairs, the mucus traps pathogens. It's sticky and it allows things to obviously hold on to them, and then you can cough them up. Okay. So it's really important that we have this structure going through all of these tubes to really protect what gets into our lungs. Okay. So we'll talk about smoking at the very end, but if you smoke, hopefully none of you do, and especially cigarettes, I'm talking about in this specific slide, just one cigarette can make these cute little cells. I feel like they kind of look like minions. I don't know. But anyway, it makes these cute little cells freeze. It paralyzes them. That is what cigarette smoke does to these cells. Just one. So one cigarette will freeze up these little guys. So then they can't beat and they can't push stuff out. So things start getting clogged. If you chronically smoke cigarettes, then you can actually kill these cells and they can no longer regenerate, and you're losing surface area, you're losing immune function, losing protection, all these horrible things. Okay, so one reason why smoking is no good. Okay, so anyway, back to the alveoli. We are zooming in on them right here. Okay, so here, three little bunches, and it's just showing you essentially here is what they would look like. Okay, kind of like a bunch of grapes. If you were to cut one open on the inside, Here's the space where oxygen would be diffusing. And then if you look on the outside, okay, this one is showing you how capillary beds wrap around the alveoli and wait for the gas exchange to occur. Okay, so just remember, in reality, all of these alveoli, all of these endings here are wrapped in a capillary bed. And this is how we go from the air to the bloodstream. Okay, so again, let's zoom in on one alveolus. So alveoli means many, alveolus is one. So let's look at what happens in one single sac. So this is an alveolar sac that is filled with air, okay? That air is going to obviously be coming in, okay, in from the lungs, so it should be really rich in oxygen. So here's the alveolar cell, okay? Right up on it, this is a capillary bed, and this is part of your bloodstream. This is the smallest blood vessel we have, which is a capillary. And you'll notice that as blood is arriving at this alveolus, it's blue. Okay, obviously, our blood's not blue, but the bluish, purplish, this represents deoxygenated blood. Okay, which should make sense because we have deoxygenated blood arriving at the lungs because it's carrying carbon dioxide that we're going to diffuse out and then expel out. Okay, so the blood that's coming in is rich in carbon dioxide. The oxygen that's coming in, sorry, not dogs, the air that's coming in is rich in oxygen and poor in carbon dioxide. So carbon dioxide will want to diffuse out of the bloodstream and into the alveolar sac because it's going to go from a high concentration of carbon dioxide to a low concentration of carbon dioxide. That is passive diffusion. Just as when we get over here, okay, the blood that is leaving the lungs is now going to be rich in oxygen. And that's because oxygen was really rich in here, in the air. But now the blood, like I said, that's at the lungs is poor in oxygen because that blood is coming to get oxygenated. So oxygen easily diffuses into the bloodstream down its concentration gradient and it just takes off. We're not going to go through all of the blood vessels that it goes through, but it goes back to your systemic circulation to deliver that oxygen to your tissues. Okay, so that's all I expect you to really understand about this. Again, you don't have to know all the names of the blood vessels, not anatomy, but just want you to know how do we get oxygen in and how do we get carbon dioxide out, aka gas exchange, at the interface of an alveolus and a capillary. Okay, cool. So, lastly, obviously, the more we have, right, the more sacs we have, the more capillary beds we have, that's increasing surface area. Okay. And the more surface area we have, the more gas exchange we can do, and thus we can get more oxygenation of our tissues. All right. So now let's talk about how do we actually get the oxygen or get the air into the alveoli? Like, how do we get it to be driven into the body? There's a kind of a misconception that your lungs are muscles or they're muscle-like, where they kind of just spontaneously contract and get big and relax and get small. And that's not really the case. Your lung tissue, like all of this pink tissue, is connective tissue. Okay, so it's not muscle, it doesn't contract. It's quite frankly like a balloon where when air comes in, it inflates, and when air leaves, it deflates. So then, how do we drive the air in if we don't have something pulling or pushing the air in? And this is where Boyle's law comes in. So we discussed this actually in the first lab when we talked about diffusion. Same concept where we're looking at the relationship between pressure and volume. So again, just picture this whole box thing where we have a box. Let's say this is 1 liter, and the pressure inside is 100 millimeters of mercury. Okay, we have the same amount of particles here and here. Now, if we push this down and we make the volume inside smaller, okay, same amount of particles, nothing has left. We've just lowered the volume by half. You notice that the pressure increases by half. There is an inverse relationship between pressure and volume. The more or the smaller the volume, the higher the pressure. Okay. This is exactly what happens in our lungs. Okay. This is how pulmonary ventilation is driven. However, this change in volume is not directly from the lung tissue itself. What your body does is manipulate this cavity called the thoracic cavity, okay, or your thorax. So you have your rib cage protecting your lungs, okay? Now, within or in between your ribs, you have muscles, okay? Those muscles that are attached to your actual rib cage, those guys contract and relax. Same thing with your diaphragm. It contracts and relax. And when it contracts, it kind of moves. So we're manipulating the space in this entire thoracic cavity, and that influences the pressure, thus, in your lungs. So we're creating a pressure gradient to push air where we want it to go. Okay. So when we make the thoracic cavity bigger, when we inhale, the pressure inside is low. When we exhale, the pressure in the thoracic cavity gets smaller and the pressure gets higher. Okay. So let's go through that. So starting off with inspiration, here is the mechanism of how do we breathe air in? How do we inspire? So the first thing that's going to happen is your diaphragm, this dome-shaped muscle that sits under your lungs, is going to contract. Okay. So right here, it's relaxed, right? When it contracts, it moves down. You can see over here, it moves down and kind of flattens. So let's wait for it to do it again. So we're doing inhalation. So see how when you inhale, it lowers and flattens. So now you have more space in here. So we've increased the thoracic volume. Okay. Second way we increase the thoracic volume is through these muscles called external intercostals. Okay. And this picture is just showing them on this side, okay, to divide inspiration and expiration. But obviously, in reality, the same muscles are on both sides. Okay. These external intercostals are just found um, kind of on the um, how do you say it? Like in between each rib. Okay. Kind of like the ribs that you eat. Kind of gross to think about, but that's really what ribs are. They are external intercostals or internal intercostals from a cow or whatever it is. Yeah, sorry if I ruined that for you, but essentially that is what it is, right? You're holding the bone and there's meat on it. Same thing with us. Hopefully you can picture that. Anyway, so when these muscles contract, what they do is, as you can see here, pull the rib cage out. Okay. So diaphragm pulls down and the muscles pull the rib cage out. So both of these groups of muscles are making the cavity bigger, increasing the volume inside the thoracic cavity. Now, when you make the volume bigger, okay, increase the volume, that means the pressure in that space is now lower. And if you recall, particles like to be where there's low pressure, where there's a lot of space. So the particles in the air, same thing. They would rather go in here, or they're actually kind of driven towards this area of low pressure. And that is what happens. That's how you inspire. All you do is kind of expand and pull open your thoracic cavity and kind of invite the air in. And it does so. It goes down its concentration gradient and gets into your lungs. Okay. So that's how we pull air in. Diaphragm contracts and moves down, and your external intercostal muscles contract and pull the ribs up and out. Okay, now let's talk about expiration. And there's two ways that we do expiration. We first are going to talk about forced expiration because it's kind of going to help us understand um, the what's it called? Tidal expiration. So, forced expiration is not something you do all the time. You can kind of think of it like a sigh, or like if you're trying to push your air out. Okay, you kind of have to, like the name says, force it out. So the best way to understand this is to do it yourself. So pretend you are blowing out candles and they're not going out. Okay, so you want to blow out and push all the air out you can until you feel like you can't anymore. So it will sound something like this, kind of like a wheeze, or maybe I have asthma, I don't know. But essentially, when you push out all of your air, try it again now, holding your stomach area. Okay, so put your hands on your stomach, try it again. And what you should feel is that your abdominal muscles are going to get hard. Your abs are going to tense and tighten. Okay. That is not by coincidence. Okay. So forced expiration now is activating three sets of muscles. First is going to be the diaphragm. Okay. But in this case, the diaphragm is just relaxing. It's not contracting. It's just going back up into its resting position, which is pushed up against the ribs. So let's see it. Here's rest. Inhale, it's contracting, going down. Exhale, it's not contracting, it's just moving up into its relaxed state. Okay, so there's your diaphragm during expiration. Also, you have now the opposite of your external intercostals, which is your internal intercostals found here. And these guys actually compress your rib cage in. So they put pressure down on your lungs. Okay. So that's going to make the cavity smaller, right? Your diaphragm moving up is making the cavity smaller. And additionally, compressing your abdomen is putting pressure in, or generating pressure inside your cavity, and thus making it smaller as well. So the end result is that you have now lowered or decreased the volume inside the thoracic cavity. So now there's a really high pressure inside your lungs, and that pressure is higher than the atmospheric pressure. So then, given what we know, air molecules, etc., don't like to be crowded. They want to go where there's a lower pressure. So they are pushed out into the atmosphere, and that is exhalation. Okay, so that's how we manipulate our thoracic cavity and our internal pressure to force out air. Now, obviously, we don't breathe like that all the time. So now let's talk about passive expiration. Like, how do we exhale when we're not thinking about it? We can also call this like tidal breathing. Okay. So now passive expiration still is going to have the diaphragm moving up. But again, remember, it's moving up, but it's relaxing. It's not contracting. Movement doesn't equal contraction. Okay. It is just returning to its resting state. Additionally, your lungs, okay, like we've discussed, they're not muscle, they're connective tissue, and they're very, very stretchy and elastic. So if something is elastic, it means that it can stretch and snap back or return to its original position. Think like if you pull on a rubber band and then you let it go, it should snap back to its original length. Same thing with your lungs. Once the air has left, or as it's leaving, the lungs will naturally shrink back to their normal size. Okay, that's simply due to their elasticity in something that we call elastic recoil. There's no active muscle contraction. Okay, so it's very important that you understand that. Inspiration is an active process. Muscles are contracting. Okay. Passive expiration, however, there is no muscle contraction. This is a completely passive process. Okay. And then again, this is different than forced expiration. If you are forcing expiration, then yes, there are muscles contracting as seen here. But when you're not thinking about it, passive expiration, there is no active contraction. All right, so let's see if we understood this. What happens during inhalation? So I'll give you a second. You can pause the video and give it a shot. Okay, so during inhalation, we have our diaphragm moving down. So volume is increasing, along with obviously the external intercostals contracting. So when volume increases, that means that pressure decreases. And so that means air would want to go to that place where there's a low pressure. And that is how we inhale. Okay, so that is the mechanism of ventilation or how we get air in and out. So there's a couple ways we can now measure these lung volumes. So we have these things called PFTs or pulmonary function tests, and they all measure how air is moving in and out of the lungs, and they are obviously used to diagnose certain respiratory disorders. One PFT, a very specialized PFT, is spirometry. Okay, so spirometry uses a spirometer, as seen here, where you would clip your nose and have this mouthpiece, and you'd be breathing in and out of this tube, which would be attached to some sensor, and it would measure the volume of air that is moved within each breath or whatever you're measuring. As you can imagine, post-COVID, this is not it. This is not a thing. So, yeah, we are not going to do that in class, but it is still important to understand the readings because they are still really relevant. So, here is the overview of the different lung capacities. Okay, so I'm going to go through them one by one, but here they are just on one slide so you can see like the big picture here. Okay, so the first lung capacity we're going to talk about is tidal volume. Tidal volume, just think of like the tides naturally go in and out on their own. So, this is the type of breathing that you do, like when you're not thinking about it, you're just sitting quietly, passively breathing. So, for most people, that is about 500 milliliters. It would look like this: breathe in, out, in. This isn't part of it. Out, in, out, in, out. Okay, next one is inspiratory reserve volume or your IRV. And it's kind of in the name. So your the volume that you can inspire at the end, okay, like what's left over. So inspiratory reserve volume is the extra amount of air you can inhale after a normal inhalation. So essentially you'd be breathing normally. So like inhale, exhale, inhale. And then at the top of your inhale, you would like that, like pull in as much air as you possibly can. And whatever that volume is here, that's your IRV. And of course, men and women tend to obviously be, or men obviously tend to be bigger than women. So women have smaller lungs, and thus they generally are going to have a little bit lower of an IRV. But don't worry about like memorizing these numbers, just something to think about. Okay, now the opposite of an IRV is an ERV or an expiratory reserve volume. And this is the extra amount of air you can exhale again after a normal exhalation. So you would breathe in and out normally. And then at the end of an exhalation, you would kind of like forcibly exhale as much air as you can, obviously before passing out. So this serves as your ERV. And this is generally the same for everyone, so long as everything is healthy. So I want you to notice that even though in this graph, this person exhaled as much as they could, they did not hit zero. And one would think that if someone's lungs are functioning optimally, they'd be able to push all their air out. But actually, we don't want to push all of our air out. We can't push all of our air out. We always have some air left over. And that leftover air is called the residual volume, okay? Or the volume of air left in the lungs, even after a maximum exhalation. And the reason for this is we need to keep some pressure in the lungs. We need to keep the air in there to keep them from collapsing, okay? If our lungs collapse, then we can't do gas exchange. So it's very important that we maintain a residual volume of about 1,200 milliliters. Okay, so with that, take a look at this example. So What would happen to the residual volume of an individual that's having difficulty exhaling all the way? So maybe they're like short of breath and they just feel like they're not able to get a full exhale or like something's in the way. Okay. Let's picture that scenario. What do you think would happen to their residual volume? Go ahead and pause the video and take a guess. Okay, so hopefully you said the residual volume would increase. So if we look here, this person is inhale, exhale, inhale, exhaling. And let's say they're exhaling as hard as they can, but they're only able to go this far. So they stop short. So that means there's this much air they were not able to push out, and so would become part of the residual volume. So you can see this volume essentially doubled in this case. Okay, so the residual volume, when it gets bigger, that means that that person is not efficiently expelling all of their air. So the answer would be 1. Okay, now, bringing this all together, we have something called vital capacity. Okay, and this essentially is the total amount of air that you can exhale after you take the deepest breath you can. So essentially, it's like pull in as much air as you can and then exhale it as much as you can. So it's essentially testing the total capacity of your lungs. So to do so, you would have to add three things together. Your tidal volume here, your inspiratory reserve volume, and your expiratory reserve volume. So it should be about 4,800 milliliters. Again, give or take depending on gender and fitness, etc. Okay, but that's not really realistic to measure. So what we can do instead is use an incentive spirometer, which is another PFT, to measure this forced vital capacity. Okay, and now this forced vital capacity, or FVC, measures the total volume of air someone can forcibly exhale after taking a super deep breath. So they used to look like this, where you would blow the air in and there'd be like a little ball or like a marker, and the air would push it to the volume. Okay. Now they kind of look like this, where you have this little, I don't know, looks like a little cylinder with some kind of marker in it. And you're going to blow air into the tube, and the marker will move based on how much airflow you exerted. And this is super convenient and a great way for doctors to measure your lung function or your lungs capacity. Okay, so that's your forced vital capacity measured with an incentive spirometer. Now, there's another PFT that we can look at. This is essentially, it's a little complicated, but this is something called our forced expiratory volume in 1 second, or an FEV1. Now, this PFT is a common one that's used to assess things that fall under the category of an obstructive lung disorder or disease. So things like asthma or COPD, okay, where you have something obstructing your airflow, meaning it'd be really hard to exhale. So, what this test does is measure, again, how much air can you exhale, but this time in 1 second. So, you're going to forcibly exhale, and we're going to measure how much of the total air that you exhaled was expelled in the first second. So, let's look at this. Here's time and then the volume. Okay. So here's 1 second, we have their FEV in 1 second. Okay. Their FEV1. That's the volume after 1 second. But their total forced vital capacity, or total FVC, is what we just talked about here. That doesn't have a time limit. It's just how much total can you push out. Then what we do is find a ratio of the FEV1 over the FVC because we want to know how much did you expel in that first second. Okay. So what that looks like here is if you can imagine, here's our total like vital capacity, right? Here's the FVC. That's how much they were able to forcibly exhale total. Then this FEV1 is a portion of that FVC. So if it was 80%, that's the ratio. That means that this person was able to expel 80% of their FVC in that first second, which is pretty good. That's really good. Okay. 80 doesn't sound great. You're like, be average, but no, in this case, that's amazing. Okay. So anything above 80 is phenomenal. And again, don't forget, we still have our residual volume down here that will always be present. Okay. So in adults, um, a normal value is about 80%. Again, if someone is super athletic, maybe they're like a Olympic swimmer, they're gonna have probably maybe 85. Okay. That's because their lungs are very, very trained. Okay. But if it's lower than 80, then that's usually indicative of some obstructive lung disease. All right. Okay, so like I said, we're not doing spirometry or anything like that. This lab activity is very simple, so you're going to do it at home. Now, I would like for you to either do it in the mirror or have a partner. It doesn't have to be someone in the class, just like mom or dad or sibling or roommate, whoever, um, just for safety, okay? Because you are going to be holding your breath. Now, priority here is safety. Do not hold your breath to the point where you feel lightheaded or dizzy. Don't make yourself pass out. Okay? That is not the point of this activity. The point of this activity is to measure your breaths per minute resting. Okay, so like pause this video after I give the instructions. Just sit there, relax for a few minutes. Place your hands, one on your belly, one on your chest. And as your chest or belly rises, some people breathe more with their belly, some people more with their chest. Whichever one is you, just go with that one. You're going to count how many rises in 1 minute, and then you're going to record that here. Once you're done after that minute, set a timer or have whoever's helping you set a timer and hold your breath for as long as you can safely. Okay. Just before you feel a little uncomfortable. Okay. So hold your breath as best you can. And then once you can't anymore, immediately, again, set a timer for 1 minute now after you record how long was the breath hold. And then again, put your hand on your chest or belly and count the number of breaths in 1 minute. Then you're going to record these three values to me in your lab for attendance points assignment. Okay, and remember that is due no later than Friday, 5 p.m. And it's very easy. All you're doing is inputting the data from this activity and activity two. Okay, so this is the breath holding experiment. Please be safe when doing so. If you have a respiratory condition, you have asthma, something that prevents you from doing this, please make a note of that in your assignment. And obviously, that's totally okay. Okay, so now let's talk about the effects of hypoventilation versus hyperventilation. So I have this term up here, apnea. So think of something like sleep apnea. It's when you stop breathing in your sleep. So apnea means absence of air, absence of breathing. So holding your breath. Okay. So we are going to see what happens to the breathing rate when you are doing hypoventilation or apnea, which is breath holding, or hyperventilation. So let's define these. Hypoventilation is when you're not breathing enough per minute. Your BPM is low. So that means there's not enough gas exchange. So if there's not enough gas exchange, that means you're not getting rid of CO2. And so CO2 is then allowed to accumulate in the bloodstream. And CO2 is very acidic. Okay, so keep that in mind. So this is dangerous. So your brain is going to trigger a breathing response in response to these increasing CO2 levels. Okay, and we'll talk about how in the next slide. Second is hyperventilation, right? So this is when you're breathing too much. Maybe you're really anxious or you're hyperventilating. Whatever the case may be, you're breathing too much per minute. So you have too much gas exchange going on. So that means you're getting rid of oxygen really quickly. And that's also dangerous because if you have such a low carbon dioxide, that can make your blood really, really basic, which is also not good. So in this case, this doesn't trigger your brain, okay? It essentially stops a signal from being sent, okay? So the absence of this acidity that's being sensed is going to fix this issue, okay? And I'm going to expand on this in a few slides, okay? But just make a note here really quick that to fix hypoventilation, the brain's triggering a response. To fix hypoventilation, the brain's triggering a response. To fix hyperventilation, the brain is stopping a signal. So they're not quite opposites, and we'll talk about why. Okay, so before we talk about the differences, let's really quickly talk about what's happening inside the blood. Okay, when we're talking about too acidic, too basic. So aside from changing the rate of breathing, we also have buffers at play in our blood that exist to kind of, like the name says, buffer out these huge drastic changes. We want to avoid big changes in our body, and these buffers help us do so. So we have a delicate balance of carbonic acid and bicarbonate. Okay, so you want to be able to recognize carbonic acid as H2CO3 and bicarbonate is HCO3 minus. All right, so let's take a look here. Let's see what happens in the blood when your plasma, okay, your blood plasma becomes too acidic. So in the case where you're holding your breath or hypoventilating, your blood is too acidic. And the reason is because carbon dioxide is very acidic, and thus in the blood, we have a high concentration of hydrogen ions. Okay, you have to remember that hydrogen ions, when they're loose in a solution, are very acidic. Okay, so to fix the acidity in the blood, we need to remove the hydrogen ions. So we have a buffer bicarbonate which can sweep up all of these hydrogen ions. Not all of them, one at a time, obviously. So one bicarbonate could come in and it can pull in one hydrogen ion. And when it does so, it becomes carbonic acid. Just notice the hydrogens. There's two hydrogens. Bicarbonate started with one and it gained one and became H2CO3, carbonic acid. So what we've done is essentially used bicarbonate to pull out all of the hydrogen ions. And when you lower that concentration of hydrogen ions, that pushes the pH more to basic, okay? Or it helps neutralize it out. So that's good. Now, what about the other way? If our plasma becomes too basic, meaning there's a low amount of hydrogen ions, we can essentially get carbonic acid to then do the opposite and release its hydrogen ion. So that's what it does. It will break down by releasing its one hydrogen ion into the blood or into the solution. And when we add more hydrogen ions to the solution, it becomes more acidic. So that then buffers out this basic situation and neutralizes out our blood. Okay. All right. So now let's move on to the stage where we talk about the CNS or the central nervous system correcting for hypoventilation. So like breath holding. So we know that when you hold your breath, that means you're accumulating carbon dioxide. And during that state, that means you have a really high concentration of hydrogen ions, and those ions are very acidic. So if they're acidic, okay, or if your blood is acidic, that means its pH is really low, okay? Because remember, a acidic pH is less than 7. Okay, and we know that our blood getting really acidic is dangerous, and our body wants to prevent that. So we have these chemoreceptors called carotid bodies and aortic bodies. and they're located at the heart and at the base of the skull, or obviously base of the brain. So, two critical organs, right? So, these chemoreceptors, what they do is sense for acidity, meaning they sense hydrogen ion concentration. So, in this case, there's tons of hydrogen ions. So, they're going on red alert. And what they do is send signals to the brain. Okay. They send signals to activate the respiratory centers in the brain. And you don't have to memorize the names, just you can say respiratory centers. What that respiratory center will do is in turn activate the motor neurons that are innervating your diaphragm and your external intercostals. So you can see here, chemoreceptors send the signal to the respiratory center. That respiratory center turns around and sends signals via the motor neurons to your external intercostals and your diaphragm. And it tells those muscles to breathe faster or increase the breathing rate. And that helps us because if you breathe faster, you're blowing off more carbon dioxide, and that's releasing, or it's lowering the, I don't want to say lowering the pH. It is making the blood more basic, okay? Bringing us closer to homeostasis. Okay, so this, remember, hypoventilation. To fix it, we activate. Now, hyperventilation, it's not quite the opposite, and let's see why. So, to correct breathing too fast, this means we have a really low concentration of carbon dioxide, okay? And thus, our hydrogen ion content is very low. So, we have a high pH. The blood is too basic, also not good. Now, if you remember, these carotid and aortic bodies are not really concerned with um, oxygen. Okay, what they're really sensing is how acidic the blood is based on hydrogen ions. So in our case here, in hyperventilation, we don't have many hydrogen ions because the blood's basic. So therefore, these chemoreceptors are not being activated. Okay, so they're not getting a signal because there's nothing to alert. There's nothing to trigger that signal. So then they don't send a signal to the respiratory centers because they don't see a reason to. So therefore, there's no activation of the brain respiratory centers. And if there's no activation in the brain, then there's no signal being sent to the muscles of respiration. That doesn't mean that they stop. It just means that there's no additional activation, um, meaning those motor neurons are sending less signals. They're not ramping up their frequency of signals. So what happens is over time, your breathing rate will naturally and slowly go back to normal. Okay. So that's why I really want you to not think of them as opposites when you think of hypo and hyperventilation, because it's not quite the same. Okay. So what I like to do is think of this situation here, hypoventilation, to fix that, to increase the breathing rate. This is like putting your foot on the gas. Okay. You're ramping up the intensity of the breathing. Hyperventilation is like taking your foot off the gas, not hitting the brakes, just lessening, okay? Lessening the intensity of the speed, okay? By removing that activating signal. Okay, so hopefully that analogy helps. Now let's see. Let's see if we got it. So here's the question. Your 3-year-old sister is throwing a temper tantrum, and she threatens that she's going to hold her breath until she gets what she wants. Oof, okay. So, which of the following is false? So, pause the video and make your guess, and then we'll go through it. Okay, so number one, CO2 accumulates. Hopefully, you're saying true. She's holding her breath, so she's not expelling CO2. Okay, pH now. pH decreases. Well, a low pH means acidic. So, if she has a lot of CO2, then that also means the blood is very acidic. So, this is true. Therefore, number three, pH increases has to be false because that means more basic. Now let's look at option four. The respiratory centers in her brain will automatically activate motor neurons, innervating the diaphragm and intercostals, and she'll be forced to breathe. That is true. So, no matter how hard you try, okay, especially in this situation, she's going to try, but eventually the chemoreceptors will be activated and start sending signals through her central nervous system, and it's going to force her to breathe. Okay, so the correct answer here to which is false would be option three. Okay, so in general, okay, this is the pattern you should see when your central nervous system is correcting your breathing rate. Okay, so like we discussed earlier in the breath holding experiment, this is kind of what you should see happen. So at first, you're going to do tidal volume, right? Normal breathing, in, out, in, out, in, out. Then you're going to hold your breath for as long as you can. And then at the end, what should happen is when you can't anymore, you're going to have this intense need to do this big sigh or big inhale, taking a huge gulp of air. After that happens, what you should see is a brief moment of hyperventilation, increasing the breathing rate, okay, to compensate for this lack of breathing, okay? And this is evening it out until eventually, after some time, the breathing rate should go back to normal. Okay, so that is what you should see. If you think about a time when you're holding your breath like underwater or something like that, just picture like what do you do when you get to the very top? You get out of the water, you've been holding your breath for a while, you go and you breathe in a bunch of air. Okay, that is the mechanism we're kind of talking about here, that deep sigh. Okay, lastly, we have our respiratory condition. So, two categories, obstructive versus restrictive. So, for an obstructive respiratory condition, these are conditions where there's a reduction in the airflow. So, you're going to have things like shortness of breath, and your forced vital capacity, like how much air can you push out, is going to be really impacted. So what causes this? There's many things that could cause it. Could be there's an obstruction to your lungs, okay, via maybe mucus, maybe water, like if you had pneumonia or inflammation, okay? Because if you have an inflamed airway, you're also impairing the amount of air that can move through, just as if your airway was filled with mucus. It's going to obstruct. So that is what we call an obstructive disorder. So things like COPD, in the name, it's chronic obstructive pulmonary disorder or disease. Asthma, okay? Bronchitis, inflammation of the bronchioles or the airway, okay, part of the airway. That's going to also cause things like wheezing and chest tightness, even shortness of breath. So those are obstructive disorders, okay? The airflow is affected. Now, restrictive disorders, conversely, these are characterized by a reduction in the lung's volume. So you're going to have a difficulty, you're going to have difficulty pulling air into your lungs or expanding your lungs. And generally, this is caused by stiffening of the lung tissue or some kind of, I don't know, hindrance or issue with the actual chest wall cavity, right? Like the muscles surrounding your lungs. So let's see, things like emphysema. So if you look over here, emphysema, what happens is the alveolar membranes of those alveolar cells start to break down and lose their integrity. So there's structure here, and now there's no structure. So these guys are not going to be able to inflate as much as a healthy alveolar sac would. Okay, so there's going to be a loss of compliance or stretchiness. Okay, so kind of like a stiffening feeling. TB or tuberculosis, obesity, or even like neuromuscular disorders like MS could also affect the innervation of those um, muscles of respiration. Another way to think about it is let's say you're wearing really, really tight clothes, which you shouldn't do, around your rib cage. Hopefully, I mean, not hopefully, if you've ever done something like that, something's too tight on your rib cage, it's hard to breathe. It's restricting you. Okay, so think about it like that. Another thing that could cause a restriction would be maybe if you had like a pulled muscle in your rib cage or you like broke a rib or something of that sort. That would cause some issues with the way your rib cage can expand and also restrict your ability to get air in. Okay, so be able to understand the difference between these types of conditions and maybe know some examples. All right, last but not least, we cannot finish this without talking about smoking and vaping because, yeah, like this is super relevant and important. So, I said earlier that your respiratory tract is lined with pseudostratified columnar epithelium. Sorry, ciliated pseudostratified columnar epithelium. And I kind of refer to them as like little minions, okay? Because they're column shaped and they have little hairs on top. So this is what I picture is happening inside of someone's um, respiratory system when they smoke. Like we said earlier, smoking just one cigarette with all of these wonderful ingredients will cause um, your epithelial cells to be paralyzed. They'll be unable to move pathogens or allergens out. Over time, what happens? They die off and they don't get regenerated. Okay, so that's smoking. That's just in the airway. The actual lung tissue itself loses compliance. This lung is not going to expand much. So it's stiffened. Also, what happens in your actual alveoli, okay, here's one alveolus, okay? There's two types of cells we have. We have an alveolar type 1 cell, which are these like light pink cells that make up the actual wall of the alveolus. Smoking actually kills these cells. They are no longer functioning if you smoke a lot, okay? I'm talking about cigarettes here. So, if you keep killing off all of your type 1 pneumocytes or alveolar type 1 cells, you are now unable to efficiently do gas exchange. That's a problem. Okay, so that's another reason why smoking is so bad, in addition to things like cancer, etc. Now, before we talk about vaping, we'll talk about smoking weed. Okay, so marijuana. I know someone was going to ask me, so let's just talk about it. There's a common misconception that smoking weed is safer than smoking cigarettes. And I can understand why one might think that, right? Because marijuana typically does not have all this stuff in it, but it's also not exactly clean either. The bottom line is inhaling anything into your lungs will irritate your lungs and will put your immune system and these immune cells and the integrity of these structures at an increased risk. Okay. Yes, marijuana does not have all of these things from generally what we know. But again, this is not FDA approved. This is not regulated. There is no quality assurance with this. So you actually don't really know what's in it to begin with. Okay. So there's that aspect. And also, the way it is smoked, okay, that combustion that occurs, there's a reason why you cough after smoking marijuana. So just think about it, okay? Still not great, okay? I'm not condoning either. Both are really bad for you, okay? Um, I understand this has, more benefits, et cetera, but please keep in mind how this affects your actual tissues in your body. Still not great. Maybe consider something like edibles. I don't know, okay? Not saying what to do, but just giving you some life info, okay? Also, with marijuana, you do have an increased risk of like fungal spores or infection. Okay, so just be careful where you're getting your stuff from. Okay, ugh, vaping. Okay, so vaping is all the rage these days. And again, another common misconception is that people think that vaping is safer than smoking, and it's not at all. It's not better. Okay, it comes with its own set of symptoms and issues. Got all worked up talking about this. Now I'm the one choking. Very passionate about this. Okay, so vaping. What's scary about vaping is that we don't have much data on the long-term effects, right? This is very new. So all we have right now is kind of like seeing the case studies compile and trends. Okay, but the trends are not good. The case studies are really bad. And the age at which people are dying from this, literal children, teenagers, okay, is quite alarming. Okay, so let's talk about why vaping is bad. Just going to get you rolling on this because one of your questions in the discussion is going to ask you to kind of research this on your own. But one thing we have found, when I say we, I mean researchers, not me specifically, um, there is, how do I say this? There are studies that are now showing us that vaping products tend to have a lot of things like vitamin E. Okay. And if you know anything about vitamin E, it's used in like lotions and creams, and it's very good for your skin because it's very like it's moist, it moistens your skin, it's very slippery, it kind of lubricates your skin. It's very slippery. Okay. And so it helps to, I guess, get the vaping contents hot, whatever. I don't know how it works, but essentially, the issue is that vitamin E, if that gets into your lungs, which we're finding that it can be transferred, it will screw with the integrity of your alveoli as well, your site of gas exchange, but not in the same way that um, smoking a cigarette would do. It does it a little differently. And what it does here is if you inhale that vitamin E or these like slippery type substances that they are putting in the vape, it disrupts this layer of something called surfactant. Surfactant is critical. Okay. So we have our type 1 alveolar cells, but the second cell that we have inside of our alveoli is a type 2 pneumocyte or an alveolar type 2 cell. The job of this cell is to secrete this fluid called surfactant. And it's this viscous fluid that essentially creates um, integrity in the alveolus to keep it open. If it doesn't create this layer, okay, of this substance, you won't have any space for air to move in and out, and you won't be able to do gas exchange. That's extremely dangerous. Okay, babies, like obviously they can't breathe in the womb, so they don't produce surfactant until they're out. But this is like very crazy. Like you need surfactant to be functioning and to get air. So just one lovely side effect of vaping. I'd like you to go look at more if you can. But hopefully, if anything from this lecture, you've learned that, these things are actually really, really bad for your health. And maybe if you can actually see um, why, that can help you kind of kick your habit if needed. All right, so with that, let's move on to the last activity. So here is the link for the meditation. You can click it here, or it's also posted in the module. And this is super easy and actually really good for you. What you're going to do is, again, just like before, I would get the video prepped. It's just on YouTube, and set your timer for a minute, record your breaths per minute before you start the meditation. Then do the 5-minute meditation. And while you're doing that, really pay attention to what you feel in your body, specifically in your chest, like in your stomach. Like, what do you notice? Okay. Because I'm going to ask you to explain in your assignment what changes did you notice or not notice? How did you feel after this? Okay. So after the meditation ends, then immediately stop, set a timer for a minute, and then get your breaths per minute after. Okay, so that is it. So once you have your results for activity 1 and activity 2, you can open this assignment in Canvas. You can just download the Word document and type right on it, or you can just create a little text box thing submission in Canvas. I don't really care how you submit it as long as you get me the data. Okay, I'm not strict on this. And again, the hard deadline though is Friday at 5 p.m. This is separate from your lab assignment. Okay, since you guys were not in person in lab, I have to actually like account for your attendance. So that is what this small assignment is doing. So if you don't submit this, then it's going to look like you were absent. Okay, so please make sure to do that. All right, so with that, that's due Friday at 5. Then by next Tuesday, you will be submitting the usual homework assignment and the usual quiz. I'll go ahead and post data early since we're not having class and I can't collect your data. I'm just going to give you a data set that's um, kind of made up just to give you some extra time. It's no big deal. Just find one from an old semester and I'll give you that. Then, of course, prep for activity 5. Okay, next week when you come to class, we will be doing physical activity. So you will need to wear athletic clothes. Okay. Yeah, so definitely let me know if you have questions about that. I'll obviously post that in the upcoming week. Other than that, not next week, but the week after is our midterm. So your study guide is now posted to Canvas. So you might want to get working on your cheat sheets and just start reviewing. All right, so hopefully this video is good. I'm praying that all is well, and I'll post it ASAP. All right, bye guys.